Ladies and gentlemen, welcome once again to another episode of the Think Clinical Podcast. My name is Hamza. Thank you so much. So there's been a dangerous obsession with cost cutting in healthcare. So people are beginning to move very strongly around lean health or lean principles in healthcare. And today we are going to be looking into that and how dangerous that could be, if I should put it that way, and some of the ways we can get around it. Again, thank you so much for joining us once again, and please remember to subscribe, like, and share. We're always happy to hear from you. Leave your comments below if you have any feedback for us or anything we could be doing better. Now, when you look at the healthcare scenario, healthcare practice is struggling with margins, and you do realize that your revenue is flat and expenses are rising, and the question you ask yourself is, what do I do? The go-to place for most operators is that immediately you have to start cutting costs. So you are reducing staff hours, you are eliminating non-essential services, you are negotiating harder with vendors, you are buying cheaper supplies, right? That's the go-to place. It really does feel proactive, it feels responsible, but it's often the beginning of what more like a debt spiral. And here's the data. A longitudinal study published by Health Affairs tracked 850 primary health care practices over 5 years, and practices that responded to financial pressure with cost-cutting measures had 23% higher staff turnover, 18% lower patient satisfaction scores, and 15% decline in patient retention. So again, everything I'm going to talk about here is based on the research. I'm not going to feed you with any nonsense that doesn't exist. Now, here's the kicker. Their profit margins improved by 3% on average, and that improvement was very, very temporary. Within 2 years, most were worse off than they were when they started cutting costs. So why does this happen? Because in healthcare, cost cutting rarely addresses the actual problem. It just redistributes the pain across to everybody who is being affected by all the cost-cutting measures that we are having in place. So let me show you how this plays out. Scenario 1, you cut medical assistant hours, reduce payroll, correct? Your immediate savings is $50,000 a year. Here's the hidden cost. Your physician is now spending 2 additional hours daily on administrative tasks, which they could have spent on clinical care. Your patient wait time is increasing by 30%. Your patient satisfaction score is dropping. Your online reviews are worsening, so you are driving patients away because 82% of patients who would walk into your practice for the first time would go online and read about you. A new patient acquisition would then decrease by about 15%. That is something that you are not paying attention to. Now, the net result, you saved $50,000, but you lost $150,000 in revenue from patient attrition and reduced capacity. That's not efficiency, that's self-sabotage. Now, we have to be very clear when we talk about these things about the difference between being efficient and being cheap. Now, what I just mentioned is being cheap because you're trying to you're just cutting around costs. When we talk about cheapness, you're reducing cost without regard to value. So you're just trying to cut costs where you need to. But when you're thinking about efficiency, you are increasing value relative to cost. We're not just cutting costs. So these are not the same thing. So here's the research that illustrates that. When you look at the research from healthcare improvements, where they studied operational changes across 400 health facilities, they found 2 distinct approaches. Approach number 1, cost reduction. Cut staff, reduce services, buy cheaper equipment, limit patient time. Approach number 2, process improvement. Optimize workflows, eliminate redundant steps, automate administrative tasks, and improve communication systems. Practices using approach number A saw an average cost saving of 8% with revenue decline of 12%. Number B saw average cost savings of 6% with revenue increases of 15%. The difference, approach B focused on efficiency, doing the same work but with less waste. Approach A focus on just cheapness. So when we're talking about this, don't get me wrong, that cost cutting overall is a bad thing. You need to understand that it could be a good thing, but you have to look at it in a different way. Now, if families practice struggling with profitability, their immediate instinct was to reduce nursing staff from 6 to 4. Instead, they hired consultants who mapped workflow through the practice. Discovery: the practice was wasting 6 hours of nursing time daily, searching for paper charts, 15 minutes per search for about 20 patients, re-entering data that existed in EMR 10 minutes per patient, handling phone calls that could be managed via patient portal 45 minutes daily. And then so they didn't cut staff. All they did was implemented better EMR workflows, trained patients to use the portal, and reorganize supplies. Same staffing cost, but 30% increase in patient capacity and a $200,000 increase in annual revenue. That's efficiency. So where cost cutting actually destroys value, area number one, when you start clinical staffing. Research from American Nursing Association found that every 10% reduction in nursing staff correlates with 5 to 9% increase in patient complications, 2 to 5% increase in readmission rates, and 28% increase in staff burnout. So when your nurses are overworked, they make mistakes, and when they make mistakes, they face malpractice risks, patient harm, and reputational damage. So when we look at this, we are looking at two: equipment and supplies. A study tracked medical errors linked to supply chain decisions. So when healthcare facilities switch to lower cost equipment or supplies, medical error rates increased by 12% on average. Why? Because clinicians were trained on specific equipment, and when you change to cheaper alternatives, you introduce unfamiliarity, and unfamiliarity creates risk. 3. Patient experience. According to Press Ghani's research on patient satisfaction, a 1-point decrease in patient satisfaction scores correlates to 1 to 2% decrease in patient volume. Negative online reviews decrease patient acquisition by 20%, and poor patient experience increased staff turnover by 40%. So when you cut corners in your patient experience, longer wait times, rushed appointments, degraded facilities, you trigger a cascade of revenue loss that far exceeds cost saving. So what actually improves margins? If cost cutting doesn't exist, what does? Let me give you a framework of what does. First of all, invest in what multiplies value. So consider data from advisory board company. Primary care practices that invested in care coordinators, an additional expense of $60,000 to $80,000 annually, saw a 35% reduction in hospital readmissions, 28% increase in preventive care, and $300,000 plus annual increase in value-based bonuses. They spend more money, they made significantly more money. Why? Because they invested in leverage, a role that multiplied the impact of their physicians rather than just trying to do the same work. Strategy number 2, automate before you eliminate. Research from CLAS shows that practices using robust patient engagement platforms reduce administrative burden by 40% without cutting costs or without cutting staff. The staff simply shift from low-value administrative tasks to high-value patient interaction. Implementing automated systems will increase your value. Now, when we look at all of this, the strategy number 3 is price-based value and not just cost. Here's the radical idea. Instead of cutting costs, increase revenue by capturing the value of what you are delivering. And when you look at the research by JAMA Network, which examined direct primary care models where patients pay a monthly membership access, 30% higher profit margins were seen than traditional fee-for-service, 40% lower overhead were also seen. So you don't achieve that by cutting medical assistant hours, you achieve it by investing in chronic disease management and other things that could help you get through that. This is what we are talking about when we talk about healthcare and when we talk about cutting costs and being efficient. You need to think about these things carefully, especially when you are roaming around the areas of profitability. Thank you so much for joining us once again. This has been another episode of the Think Clinical Podcast. We will see you in our next episode.